Fowler-Post Gastric Surgery Syndromes, Becky Fowler, Dietetic Intern, April 15, 2015, Highlander, Marcia Pedini, Registered Dietitian. The patient is a 65-year-old Caucasian female admitted into the long-term care facility Highlander on January 12, 2015. Her primary diagnosis and reason for admission is an abdominal hematoma that developed status post Roux-en-Y gastric bypass surgery and ventral hernia repair. She required wound vacuum-assisted closure at the surgical site for the hernia. Upon admission, she had a standing order for a full liquid diet with nightly cyclic total parenteral nutrition and immunonutrition via PICC line. Primary diagnosis at admission was the abdominal hematoma, followed by morbid obesity, type 2 diabetes mellitus, hypertension, hyperlipidemia, Roux-en-Y gastric bypass surgery, and ventral hernia repair. She is divorced with one grown son and is a retired social worker. Her height is 66 inches. She weighs 360 pounds and has a BMI of 56.4. The patient is morbidly obese with a history of overeating, but at that point in time, she was on a full liquid diet, which is mostly seen 1 to 2 weeks after gastric bypass surgery. However, 4 weeks after surgery, the patient was still on this diet due to complications. She is also receiving TPN and immunonutrition to supplement her PO intake. She's receiving 90 grams of protein, 150 grams of dextrose, 50 grams of lipid, and the micronutrients which are listed on the screen. We will now discuss the pathophysiology of the patient's disease states. An abdominal hematoma is defined as a collection of extravased blood trapped in the tissues of the skin or in an organ, resulting from trauma or incomplete hemostasis after surgery. The blood clot tends to harden, which often causes pain for a patient. Research has shown that this is a common complication for ventral hernia repair surgeries, especially patients with morbid obesity, diabetes mellitus, and an American Society of Anesthesiologists score of equal than or greater to 3, which this patient scored above that in pre-surgery. Morbid obesity, also known as extreme obesity class 3, is defined as an excess of body fat or weight of 100 pounds over ideal body weight and increases the risk of developing cardiac and endocrine disturbances. It is caused by consistent excessive intake of energy, leading to persons to have body mass index greater than 40, may cause comorbidities to develop such as diabetes mellitus, hypertension, hyperlipidemia, cancer, and other disease states. Many patients suffer with morbid obesity, and for some, surgical intervention will be required to assist in their weight loss. In this particular case, the patient underwent the Roux-en-Y gastric bypass surgery, which was an appropriate weight loss tool given the patient's past medical history. Diabetes mellitus type 2 is a progressive disease characterized by hyperglycemia due to increased insulin resistance and beta cell failure. Signs and symptoms may include polydipsia, polyuria, elevated pre- and postprandial glucose levels, and an elevated hemoglobin A1C lab value. It accounts for 90 to 95% of all people diagnosed. Common medications include glipizide, which is a sulfonylurea, metformin, a biguanide, and insulin injection. Studies show that prevalence peaks between 60 to 74, and almost 30% of this population already have a diagnosis, and that number is expected to increase over the next 20 years. Thankfully for this patient, she was able to discontinue her use of oral diabetes medications, but she still continued to check her blood sugars every 6 hours and was administered a sliding scale Novolog PRN. Hypertension, also known as high blood pressure, is a function of cardiac output multiplied by peripheral resistance. The diameter of the peripheral blood vessels constrict, causing the heart to work harder to circulate blood through the body. There are 4 categories, which you can see listed on the screen. There's normal, pre-hypertension, stage 1, and stage 2. And research shows that greater than 50% of adults over the age of 65 have been diagnosed with hypertension. Most common medications include diuretics, ACE inhibitors, and beta blockers. And patients such as this one who have hypertension and type 2 diabetes are at even greater risk for stroke, renal disorders, or death. Hyperlipidemia is defined as an excess of lipids in the blood that is characterized by elevated cholesterol, low-density lipoproteins, and triglyceride levels, and decreased high-density lipoprotein levels. This can cause a buildup of plaque in the blood vessels and potentially lead to increased blood pressure, stroke, myocardial infarction, and potentially death. And there's one medication that is the most common, and that is a statin medication. Timeline of medical events. On December 10th, 2014, the patient presented to Toby Hospital for Roux-en-Y gastric bypass and the abdominal ventral hernia repair. On December 17th, 2014, she presented again to Toby Hospital due to the lower abdominal hematoma that had developed. On December 18th, 2014, the wound vac was placed to the umbilical site to assist in closing the abdominal surgical site. On December 31st, the patient was discharged and transferred from Toby Hospital to New Bedford Rehabilitation Center. On January 12th, 2015, the patient was discharged from New Bedford and transferred to Highlander. On January 19th, 2015, the dietetic intern and registered dietitian had the initial nutrition assessment meeting with the patient. On January 29th, 2015, the TPN was discontinued and the patient's diet was upgraded to the bariatric diet of soft or ground or pureed foods. On February 6, 2015, the dietitian and the intern meet with the patient again to discuss preferences and ensure appropriate foods being received from the kitchen. February 16, 2015, the patient is discharged home. The coordination of nutrition and overall care. Collaboration began between the registered dietitian and intern and the other medical professionals by establishing the patient's nutritional needs and obtaining written orders by the doctor. The next step was conferring with the pharmacist about appropriate TPN mixture. For this patient, a 3-in-1 mixture containing all 3 macronutrients plus micronutrient supplementation was used. The coordination of care was then continued to take place with the assistance of the nursing staff, certified nursing aides or CNAs, doctors and nurse practitioners, and the dietary department in the kitchen. These are the topics I will be discussing for the nutrition interventions. Here is a chart explaining the nutrition guidelines, interventions, and whether or not the guidelines were followed. For the Roux-en-Y, full liquid diet progressed to pureed or soft diet. It goes from clear liquids for 1 to 2 days to 1 to 2 weeks of full liquid, 3 to 8 weeks of soft or pureed diet, and after 8 weeks the patient can consume solid diet for their life. We did proceed to progress the patient in this manner. She also received 60 to 80 grams of protein per day, and these guidelines were followed. The patient progressed from the full liquid diet to pureed and soft foods, receiving 90 grams a day of protein from the TPN alone. For the TPN, it is only preferred over enteral nutrition if the GI tract is inaccessible or not functioning, or if there is severe diarrhea. This patient was placed on TPN due to the gastric bypass and the stomach needing time to heal. These guidelines were followed. The patient was on TPN for 2 months to heal, and PO intake was reestablished. The TPN was discontinued. Immunonutrition may or may not be recommended depending on the reason for the need of parenteral nutrition. The patient was supplemented with potassium acetate, potassium chloride, potassium phosphate, sodium acetate, sodium chloride, sodium phosphate, and zinc. And although it may not be necessary after surgery, it can be beneficial for wound healing and decreased length of stay. Type 2 diabetes is a basic breakdown that's based on the TPN alone, and it does not include any of the patient's PO intake, so these amounts are appropriate. For hypertension, the DASH diet is generally recommended, but it was not implemented because this diet order is not offered in the facility. And hyperlipidemia requires a low saturated fat diet, which was used because the patient is status post gastric bypass and requires a low fat diet. In conclusion, the evidence-based research and recommendations made by the interdisciplinary team, I feel that this patient received the appropriate care and nutrition interventions. The doctors, nurses, and other healthcare team members were open to recommendations made by the dietitian and the dietetic intern. There were several aspects that had to be taken into consideration, such as the patient's age, BMI, and variety of comorbidities and disease states. The interventions and collaboration of care enabled the patient to regain her health and go home, where she will be able to truly begin her weight loss journey after gastric bypass surgery.